Well, my goodness, thank you so much, Dorothy. That was such a very, very kind introduction. So I'm very pleased to get a chance to talk to you about our team's research today. This will be a bit of a whirlwind presentation, but hopefully it will give you a nice overview of the content area. So just to start with some disclosures, you can see funding that I have here. All of my grant support comes from nonprofit or federal foundations, and I do some consulting with a group out of London, but it's unpaid. So in the United States, I would put forward that we do a wonderful job improving care in places that look like this. If you live in a place that looks similar to these pictures, you can access high-end technology, wonderful medications, and state-of-the-art healthcare. However, within the United States, perhaps we do a little bit worse, and in fact, I would say we do a lot worse within places that look like this. And improving health in places, neighborhoods of this sort, becomes much, much more challenging and is something that is critically important. I would put forward also that this is one of the most important questions that faces us as a society in our generation, of how can we improve health in places like this? And it's a great motivator for myself as well. At the end of the talk today, I hope to convince you that where you live impacts your health fundamentally. And ultimately, where I grew up actually looked a lot more like those latter pictures than it did the former. So this is a very personal journey for me as well. My overarching program of research works to develop practical approaches towards the elimination of health disparities and the promotion of health equity, with an emphasis on the word practical. We spend a lot of time thinking how we can translate knowledge into real-world policy and real-world practice. The objectives for today are to identify the impact of social determinants of health, and particularly neighborhood disadvantage, to define some methods for quantifying neighborhood disadvantage for the purpose of research, clinical, and policy application, to recognize the need for research to promote increased understanding for fundamental sociobiological mechanisms of disease and health disparities, and to define data democratization, cite a real-world example, and recognize its import in catalyzing real-world change. So I'm going to start with some definitions. I would hope that all of you know these definitions already, but I didn't want to make any assumptions. Some of you may have encountered these concepts, but not all. So first of all, what are social determinants of health? They're the conditions and the environments in which people are born, live, work, play, worship, and age that impact a wide array of health, functioning, quality of life outcomes, and risks. This is a definition that's put forward by the Centers for Disease Control in the United States, and it has been adopted by the World Health Organization. The social determinants of health encompass a number of different constructs. You can see here economic stability, education, community context, health, but also neighborhood and the built environment. The second definition of a construct that I'll use throughout this talk is the concept of socioeconomic disadvantage. And it's the state of being challenged by low income, limited education, and substandard living conditions for both the person and his or her social network. Unfortunately, socioeconomic disadvantage is very, very common within the United States and tends to be directly related to racial and ethnic minority groups, but of course can cross racial and ethnic lines. When we look at factors that impact health from a very broad construct, you can see the CDC's pyramid here. And in health and healthcare research, we tend to focus on the tip of the pyramid, on things like education, clinical interventions, and developing new cures. These are critically important, but ultimately when we look at the weight of impact that can come about by focusing on socioeconomic factors, you can quickly see that health can be impacted profoundly by tackling some of these big issues like poverty, education, housing, and inequality. We also know that certain diseases disproportionately impact racial and ethnic minorities and the socioeconomically disadvantaged. These include things like Alzheimer's disease. We've heard about this today from Dr. Whitmer, diabetes, heart disease, many other conditions. And many of these populations are exposed to neighborhood disadvantage this social determinant of health that influences the context in which one lives. So where one lives influences one's exposures to certain types of health parameters, like access to food. It can be very, very difficult to access healthy food, to have clean drinking water, to be in a safe environment, or to engage in healthy lifestyles. Exercising 3 times a week, for instance, if you're living in a neighborhood that's highly disadvantaged, is not an easy thing. And certainly from decades of research, we know that living in disadvantaged neighborhoods are strongly linked to increased mortality and disease. Context is fundamental to almost every theoretical mechanism of health disparities that's put forward within the literature. So I've just pulled one here. This is the official framework from the National Institutes of Minority Health and Health Disparities. And as you can see, when they look at domains of influence, they range from the biological and the cellular all the way up to the built environment and the sociocultural, across the life course and across the individual, interpersonal, community, and societal levels. So I would also argue that if we aren't thinking about context within the frameworks of the types of research that puts forward, perhaps we're not getting the full picture of impact of health. So high quality studies suggest that where you live impact health, as I've said before. But interestingly, it also shows that where you live may impact your health over and above your individual socioeconomic status. So let me say that in another way. If you are poor, it is better for you to live in a more wealthy neighborhood than if you are poor and living in a highly disadvantaged neighborhood. There have been a number of studies now that suggest that health outcomes are significantly better regardless of SES. And so certainly we need to learn more. And I am massively oversimplifying the data in this area, but ultimately there seems to be an independence of these two factors, which is interesting. So how do we learn more? We need to be able to quantify these concepts of disadvantage within a contextual area so that we can look into the mechanistic underpinnings of some of these associations. Yet much of the research in this area relies on the application of geospatial analytics. It is an area that we have been very fortunate to have in great depth here at the University of Wisconsin, but it is not available in many other places. It is a great barrier in order to allow for more contextual factors to be included in NIH-funded research. And so because of this, neighborhood level factors are not typically incorporated into many public data sets. So what are some of the potential of these geospatial metrics of disadvantage? Well, they're quite robust. They're generalizable to the full US and Puerto Rico. So regardless of where someone is residing within those areas, we can say something about their context. They incorporate well into predictive analytics. They're very statistically flexible. They facilitate mechanistic science. They're privacy compliant. I can share them freely over the web, for instance. And they have an extremely strong track record of application, but primarily in Europe and in other non-US settings. They're translatable. They're quite actionable at the person, community, research, and policy level. Using maps and other ways of showing these metrics, you can guide outreach and targeting. We can influence intervention design, and we can think about how policy could be changed using such metrics. Things like eligibility, adjustment, resource targeting, all can be influenced by such things. And yet, as I mentioned, they're greatly underutilized. Metrics of geospatial metrics of disadvantage are not traditionally incorporated within policy constructs within the United States. This is Sir Brian Jarman. I had the great pleasure of meeting him, and he is the person who originally developed one of these first geospatial metrics of disadvantage for the UK. As you can see here, this was from his original publication back in 1984, in which he was trying to quantify neighborhood disadvantage or neighborhood disparities within the UK in order to more effectively target extra payments for physicians who worked in those areas. He had noted that within these disadvantaged regions, they had a very difficult time attracting providers to work in those areas. And because of that, by creating this index and then linking it directly to payments, he was able to rectify some of that problem within the UK. And that was actually why he was knighted ultimately by the Queen. This change in policy in the UK went forward during the Thatcher administration. This was in the 1980s. So places like the UK, places like Sweden, places like New Zealand have been using these types of metrics for decades, and yet, once again, they haven't been applied in the US. So we were really interested in this. We thought that perhaps these geospatial metrics of disadvantage could have quite a bit of applicability from a research standpoint, but also from a policy standpoint within the US context. So we started looking at existing metrics that had been created and came across this one called the Area Deprivation Index, which was created by the Health Resources and Services Administration nearly 3 decades ago, but used just at the county level and really for just associations with mortality. It uses 17 different metrics originally drawn from long-form census, and it required a lot of updates for modern use. So we saw a lot of potential here. We thought it was a metric that had a good track record of application. It had a foundational philosophy that looked a lot like the metrics that were created in Europe. And so we decided to spend quite a bit of time updating and validating this metric for the US. So we received a grant from the National Institutes of Minority Health and Health Disparities to do so. And we refined these metrics down to the census block group level or the neighborhood level and updated them to more recent data sources. So when you typically think about contextual disadvantage, often for those of you who are researchers in the room, you think about it at the county level. This is obviously the state of Wisconsin. The blue counties are the most disadvantaged. The lighter colored counties are the least disadvantaged. But the problem with these very large geographic areas is that even within those, within each of them, there's quite a bit of pattern of variability which isn't accounted for by the large county level metrics. So for instance, within Madison, we all know that we have pockets of severe disadvantage, and yet you don't see them on this level of geographic map. However, when we take things down to the census block group or the neighborhood level, what we get is a much richer pattern and a much more precise estimation of disadvantage within a particular context. All of the maps I'll be showing you today are oriented so that the red areas are the most disadvantaged and the blue are the least disadvantaged. So very quickly you can see that some of those cores of highly disadvantaged areas within Madison surrounded by the kind of sea of blue within the suburbs. Now, if we look at Milwaukee County in a much greater granular detail, you can also see quite a bit of pattern of variability arise as compared to the county level estimates. There are neighborhoods within Milwaukee that are some of the most wealthy within the state. And you can see the great depth of need and the great depth of disadvantage within inner city Milwaukee. So by having a much more refined geographic method to target resources, we can think about measurement of exposure and application of policy in completely new ways. But of course, the power here is that we can do this for the entire United States, every city, every county, every state within the country. So suddenly we can start thinking about looking at metrics of disadvantage and how they associate with a whole host of other factors. We can also think of them as adjustment parameters for quality of healthcare systems. I've just gathered 3 of the latest papers that have come out from this work, and it gives you a robust sense of the breadth of applicability here. And we've worked with researchers across the country to look at a number of different associations. I'll talk about the Alzheimer specific associations in a moment, but everything from maternal fetal health to pediatric infections and outcomes, to policy level Medicare Advantage plan performance, older adult functional loss, and many, many others. Additionally, We've been approached by a number of policy entities, especially at the state level, to use such metrics to inform how state level policy is moving forward and to catalyze new partnerships amongst communities, health systems, government, and even industry in ways that haven't been done before. Additionally, they're very helpful in delivery, both from an outreach standpoint and from a design standpoint. So we worked directly with this program. The Everybody with Diabetes Counts program is a program, it's the largest national diabetes self-management program that the Centers for Medicare and Medicaid Services runs. It touches every state within the nation, and it's focused on trying to improve diabetes health disparities across the country. They approached me because they were having great difficulty reaching and engaging vulnerable populations within all areas of the country. There were a number of practical barriers, including misalignment of where the outreach activities were as comparison to where the greatest need was, difficulty for these programs to really efficiently target populations that needed the services, and also issues with trust in which when they went out into the communities, they immediately asked someone to fill out an eligibility form with lots of personal information in order to qualify for programs, and that would turn off certain populations and they would walk back out the door. So they were interested in whether they could use geographic methods in order to broaden eligibility. And again, as I mentioned, this is a technique that's used in the UK and has been used for decades. So they thought, well, could we broaden eligibility to be inclusive of the 10% most disadvantaged neighborhoods within each state? So that with program targeting and outreach, if the programs were held within these highly disadvantaged areas, the people on the ground could take credit or accept everyone who walked in the door regardless of the additional information they received. So it simplified ground level operation, and it allowed them to massively increase their program reach and volumes. So here's an example, for instance. This is the city of San Diego by ADI Decile. So this program would target the red areas. And if they could set up shop within those highly disadvantaged areas, again, they were much more efficient in their targeting and outreach. This got some attention by the Centers for Medicare and Medicaid Services, and we're really hopeful that this will just be the beginning of a broader way of thinking about how an individual might qualify for services through Medicare and Medicaid. What about intervention design? Certainly, models of care developed in academia often have limited penetration into low resource settings. If we don't design a program specifically for disadvantaged low resource settings right from the start, it is difficult for those programs then to disseminate or to impact such areas. And so we do need interventions which are feasible, sustainable, and effective within low resource environments. So an example of this in which we've used some of these techniques and these targeting metrics would be the Coordinated Transitional Care Program, which targets persons with dementia. So CTRAC was designed specifically for extremely low resource settings. So it's a very different way of thinking about program design. And ultimately, it ended up being quite feasible and quite successful within academia when we started it. It cut rehospitalizations by a third. We had a return on investment of over 400%. You can see one of the hospitals here, the outcomes were very strong. However, again, this was designed specifically for low resource settings. So in working with, again, with the Centers for Medicare and Medicaid Services, they funded us to try to launch this program within these extremely red areas on the eastern border of Colorado. And again, these are the most disadvantaged areas within Colorado. We were launching the program within hospitals that were on the verge of bankruptcy, trying to improve dementia care outcomes within places that were really extremely low resource. And ultimately, we were able to launch the programs, sustain them, and show an improvement in outcomes, which is very exciting. But this idea of thinking about these disadvantaged areas, thinking about them in your design, and then targeting programs specifically towards them gives us additional hope of really moving the needle on some of the health disparities that are in our community. So another question that we were interested in knowing now that where you live impacts your health, we were interested in starting to delve into the how and the why of this, starting to understand a little bit more about what are some of the basic biophysiological pathways that could be linking some of these adverse outcomes to these exposures. And this brings us to dementia. So dementia due to Alzheimer's disease, as you well know, disproportionately impacts these populations. And a slide pulled directly from Dr. Whitmer's work shows us that racial and ethnic minorities, in particular African Americans and Native Americans, are especially impacted by these patterns of incidence. But also, when we look internationally, income tends to predict risk as well. So when you compare high-income countries as compared to the low and middle-income countries, you can see here that the number of persons with dementia is quite high and continues to increase. So this association between neighborhood disadvantage and Alzheimer's disease really remained unknown, but it brings with it a very important question for a number of reasons. One, of course, it can help facilitate mechanistic studies, and we've heard about some of the really wonderful mechanistic work that's gone forward today, and that's absolutely needed. But also, the neighborhood can be targeted in a number of different ways. So even if it's a marker for disease, it could potentially be something that's translatable to a policy relevant context so that we can try to target resources more specifically to these areas, to fund dementia outreach programs, to fund new types of care, to fund new types of intervention, and to learn more about the associations that those bring about. There is some intriguing evidence that environment does impact the brain in pretty important ways. In fact, if you take mice and you put them from a typical mouse cage, which is in picture B, and you put them in Mouse Disneyland, a very enriched environment. If I was a mouse, I'd rather be in cage A. But when you do that, interestingly enough, it changes the hippocampus in pretty profound ways. And this interaction of the environment with the brain, there may be many different reasons or different factors that are moderating this, but it is quite interesting. And you think along someone's life course, if they're living in what is equivalent to a mouse cage B, is their brain fundamentally changed because of those exposures within that context as compared to mouse cage A? Of course, people are not mice, and I'm not saying that they are in any way, shape, or form, but it's quite clear within the United States that we have certain populations that are desperately living in poor conditions that are not acceptable in any way, shape, or form. So any way that we can think about how that impacts the brain and how we can intervene upon that is important. So in this work, I was very fortunate to get to partner with a brilliant neuroscientist, Barbara Benlin, who's somewhere here. And we are working very hard to start examining the impact, mediators and moderators, of exposure to these disadvantaged contexts on the development of Alzheimer's-specific neuropathological features, vascular burden, and cognitive decline. Our hypothesis is that larger and earlier exposures to disadvantage will predict greater risk of disease. And we are just beginning to forge forth into this data. So when we look at cognition, for instance, as according to neighborhood decile, from least disadvantaged on your left all the way to most disadvantaged on the right, regardless of the type of cognition we looked at, those persons that were coming from the most disadvantaged neighborhoods were performing in a lower way on those tests. After we adjusted these for age and education, the effects were still quite robust. And so we were interested in whether some of these early findings could translate to biomarkers and neuropathology. Now, the biomarker data is still in process, and we're still working through that, and it continues to be of great interest. And perhaps I'll be able to show that to you if I come back again. But We have also been working with the neuropathological data. And you might ask, how do we do this? How do we assign a neighborhood to brains that have been donated to brain banks? And we can do this through residential history. So we can start with where someone lives at the point of brain donation, learn more about that particular context, and then work backwards in time in order to create a residential history that allows for life course parameters to be assigned. So these are brains from within the University of Wisconsin and the University of California, San Diego ADRC brain banks. Overall, we had 434 to start with who had addresses that could be geocoded. These are addresses just at the time of death, the residences at the time of death. And you can see we had groups which did represent highly disadvantaged neighborhood groupings as per a state-based construct. So we had a nice distribution of brains across our primary variable. Their age was quite similar, so most of them were in their 80s. Most, about 50%, were male. And then when we looked at the autopsy reports for these individuals, looking at neuritic plaques and diffuse plaques, you can see we started to see some differences. And ultimately, when we looked at the outcome of neuropathologically confirmed AD, residence in a highly disadvantaged neighborhood at the time of death was predictive, even within this small cohort. And this is the wonderful work that is being led right now by Jamie Larson and Leah Villan here. And please, they both have posters on this. Please stop by and talk to them about that today. So that work will continue. We're just scratching the surface, and there's a lot more to be done, obviously. But one of the things that drives me is trying to figure out how we can actually change the real world. So how do we catalyze change? And I would argue that although academia is part of it, it is not anywhere near the whole picture. In order to truly change policy, in order to truly change the way our system works and to influence any of these health disparities, I feel that we need to break outside of academia. And that is what we'll talk about next. So data democratization. This is a concept that comes from IT. It's a concept that comes from places like Google. It's this idea that you can take big data constructs and make them available for anybody to tap into to learn something new. But in order to translate big data from its raw form into something that's usable for a wide-ranging audience takes a lot of thought. So making these complex data easily available to wide-reaching expert and non-expert audiences to massively broaden uptake and use of critical concepts and tools. I would hope that each of you takes this idea to heart, and I'll show you how we've tried to operationalize this on our team. But I think we in academia can do a lot more to reach outside of our own communities, our own academic communities, in order to work with other individuals who can create change as well. As I said, this is extremely challenging. It is not easy to do, and our efforts in this regard have taken a good portion of 3 years. So our first step in the area of data democratization has been the Neighborhood Atlas. So I'll show you examples of what this looks like. It's a free research tool which makes neighborhood disadvantage metrics for the full US and Puerto Rico easily accessible through real-time customized mapping and easily linkable data downloads. Our goal was to try to make these data approachable and accessible by everyone within the community, regardless of their education level, regardless of where they worked, regardless of whether they had a data analyst within their reach. You don't need geoanalytics expertise. And that has been a huge limitation within our field in general, is the scarcity of geoanalysts within most areas. Anyone can map. It works a lot like Google Maps. So if you can use a smartphone, you can use this. And the data downloads that can be linked to existing data include a crosswalk with over 70 million 9-digit zip codes. That crosswalk took us 2 years to build. It was a massive technical task, and certainly So much of this effort was spearheaded by Bill Buckingham, who's a scientist with the Applied Population Lab and affiliated with our group. So here's the Neighborhood Atlas. You can download data for free. You just have to register some information. But the most popular area of the atlas has been the mapping. So you can choose any state within the country. You can see here the downloads or the options. This is Maryland. And very quickly you can see that Maryland is not equal across Maryland. Obviously there's Baltimore and then there's almost everywhere else. And so by getting a sense of the differences that are so profound within these different states across our country can be very important on a whole host of levels. One can zoom in to see street levels so that you can target specifically and understand exactly where these neighborhoods lie. And also you can view states from different vantage points. So this is Mississippi from the vantage point of Mississippi, Mississippi compared to itself. And this becomes very important for local policymakers if they're trying to target resources or make decisions at the state level. However, if I'm a national policymaker or a national decision maker, I'm interested in seeing Mississippi from the national perspective. So if you touch the national button, suddenly you can see how Mississippi compares to the rest of the United States. I would argue that perhaps this is why Mississippi has such challenges across a whole host of domains, not just health, but they're obviously dealing with a great degree of challenge. So this work, we introduced this tool back about 5 months ago. It was published in the New England Journal of Medicine, and I have to say, it's been one of the most impactful things I've done. I would say this is not traditional research like we usually think about it in academia. Often we're thinking about running models or getting certain results and certain outcomes. This was really about just making a tool available to an extremely wide audience. And yet it's the thing that I've had the most people contact me about. It's really been wonderful. So it's had, thus far, since its release, it's had over 80,000 views, with the vast majority focused on mapping. We've had over 5,000 data downloads, and I'm so happy to say 3/4 of those are outside academia. The vast majority are outside academia, and this is how it should be. Very, very happy about this. Some representative users. So we've had folks from Congress, the US House of Representatives, Social Security Administration, NIH has been promoting it quite aggressively, CDC, VA, AARP, pharma, other types of industry leaders. And the feedback has been wonderful and positive. I've gotten emails from groups like Play 360 that try to get grant funding to build new playgrounds within disadvantaged areas, and they'll use this as a targeting metric for that. I've had groups that do reading outreach within disadvantaged areas, and they're thinking that this could be a new way to help their on-the-ground forces to target more effectively. So it's interesting in that it will probably, for myself, just result in this one publication, but from an impact standpoint, it's truly been phenomenal. So thinking about this idea of translation of data to wider audiences, I think is something that we can continue to do as an academic community. So what are some of the potential next steps here? We'll be updating the ADI, the underlying metric on the atlas at least every 5 years, possibly more frequently. There are opportunities to develop tailored metrics to specific outcomes. So for instance, we can think about particular health outcomes and develop particular targeting metrics for those outcomes. Within the UK, they have an entire branch of government that thinks about housing and workforce and community, and they create these types of metrics just for those different efforts. There's opportunity to catalyze translational research in new ways, to think about multi-stakeholder community interventions that bring together people around a particular geography and not just around a particular outcome. So one example of this is everyone who lives, works, touches, and cares about a particular disadvantaged community could come together around a table and think about how they can improve healthcare on a broader scale. And I would include industry partners in that, policy, academia, healthcare, and a very broad array of stakeholders. You can think about clinical trial and cohort recruitment in new ways, thinking about specific targeted outreach towards these disadvantaged areas. And this has been of great interest to a number of ADRCs that have actually contacted me on that. And thinking about socioeconomic contextual disadvantage as another spectrum of clinical outreach. And of course, the maps make it somewhat easy to do on the ground level. Not that recruitment is ever easy to do, but at least they have a place to start targeting. We can think about epigenomics in new ways. So by linking these parameters to genetics data or other existing data sets, suddenly you can start thinking about some of these social determinants of health factors and how they may be influencing some of the basic biophysiological processes. And then finally, I think something that's particularly exciting is this idea of linking social science with basic science. I think there's so much more to be done here, and I know many people in the room actually do this in really phenomenal ways. But this idea that a basic science finding could then be translated into a policy initiative just blows my mind. I mean, isn't that exciting? The idea that, you know, if we can show some of these connections and some of the ways that living in these disadvantaged contexts drive diseases, and that the answer really ends up being about changing the way we think about resource allocation within our country, changing the way we think about healthcare delivery. It's very exciting. Of course, we need an entire community of people to do this. I'm a big believer in communities and creating is being needed to create real change. And we'll just start scratching the surface in Alzheimer's disease, but one could do this across a whole host of diseases. So in conclusion, I hope I've convinced you that the social determinants of health, including neighborhood disadvantage, are a fundamental driver, or one of the fundamental drivers, of health and health disparities. There are many others as well, and I don't want to lessen the importance of those other drivers in any way. This is just one of many. Neighborhood disadvantage can be quantified for purposes of research, clinical, and policy application, and the Neighborhood Atlas is our first effort to do that and to democratize the data. And then we need more research to promote increased understanding of these fundamental social science biological connections to understand biophysiological mechanisms of disease and whether some of these biophysiological mechanisms are driving disparities, and in turn, whether they could give us new pathways towards therapies, towards other types of treatments, towards better understanding of the diseases that we care so much about. So none of this would be possible without an entire team of individuals. And of course, I've flown through this data very, very quickly, but you can see many, many thank yous here. And this is our team at the Health Services and Care Research Program. So I want to thank you very much for your attention, and I'm happy to take any questions.
Hello, thank you for sharing your research with us. I'm very curious about updating the ADI over time, and will previous years' information be available to researchers so we can track changes over time?
So absolutely. If resources were limitless, we could do this every year, potentially. The ADI is built out of a data repository that represents 5 years of a period. So our next update will be coming out this year. It'll be for 2015. There's always a bit of a lag of these data. And then we hope to get on the 5s and the 0s, so 2015, 2020, 2025. That being said, for individuals who, we will often produce specialized data sets for different groups too. So if it's of interest to you and you'd like to collaborate, we could absolutely talk about that and talk about what that would look like in order to develop an ADI that was specific towards the time frame of interest. We also are working very, very hard as part of that wonderful award that I have with Dr. Benlin to develop retrospective historical ADIs, or a version of ADI. It's not exactly the same because the data that are available aren't exactly the same, but we will be having those all the way back. The vision is to have them all the way back to 1910. So although those data will be difficult to democratize, to make open to the public, because they are very specific, probably for a research construct, they could potentially be applied to a number of different life course studies that are either in existence or could be informed by greater precision of contextual metric exposure. But yeah, there's lots to be done. I'm always happy to chat. So.
Two brief questions. First of all, have you detected any type uh, of influence that economics, personal economics or income has upon those people that voluntarily decline medical treatment, like those who don't want it for religious reasons, or who don't believe in vaccinations, or who think that fluoridation is a UN plot, or whatever? Does economics have any bearing on those type of people? Then my other question, just very brief, do you know if researchers in the UK are doing the same thing with the British postcode that you're trying here with the 9-digit zip code? Thanks.
Yeah, those are both very good questions. I am sorry to say I am not qualified to answer the first, just because those areas aren't within my my knowledge base. So I do apologize. I'll have to pass on that one. In terms of the British system for these indices, they are incredibly robust in the way that they're able to develop these types of metrics. Right now, the most detailed area that we can get to is the census block group in the US, which includes about 1,200 persons, so all persons in the population. Within the UK, they have metrics that get down to sometimes 400 persons, like very, very tiny, very specific geographic areas. And it's because their census has now been designed over the last 30 years to be able to do this level of assessment. So they're building their public data record collecting system in some ways to specifically build indices like this. So it is, for us in the United States, I feel like we're in the infancy right now. I feel like my main job is to get people to start thinking about these metrics, to get people to use them, to be aware that they're out there and that they could be translatable to policy, and then talk to policymakers and help them understand that we are not the UK, we're not Switzerland, we're not New Zealand, but we can still learn from some of the approaches that go forward there, and perhaps take some of these metrics and apply it to our own directionality as a country to inform a whole host of decisions. So thank you for the questions. All right, thank you all very much. I appreciate it.